You are listening to the Movement Therapy Podcast.
Hello and welcome to another episode of the Movement Therapy Podcast, and welcome to our first episode of 2025. We thought we'd release a really special episode to kickstart the year to continue with our theme of the knee and all things ACL that we started in December last year. So over the next 2 episodes, we're pleased to announce that we are joined by Dr. Tom Cross of the Stadium Clinic up in Sydney to talk all things cross-bracing protocol for ACL tears. Dr. Cross has been a sport and exercise physician for the past 25 years, and during that time he's worked on so many different sports and athletes, from NRL teams, AFL teams. He's worked in the Cirque du Soleil, basketball. He's consulted for so many different teams. The list goes on and on, while working clinically as well. And recently Dr. Cross and his father actually developed the cross-bracing protocol, which is a way to manage ACL tears non-surgically and still be able to rehab patients to 100% and getting back to their sport. So this is a really exciting protocol for us as practitioners. And I wanted to obviously chat to Dr. Cross to get his breakdown on what the protocol actually is. So this first episode is explaining what the protocol is, as well as the different variations of the protocol, and who is actually eligible for the protocol and what it consists of. So it's a really interesting world if you haven't heard that ACLs are able to actually heal themselves, or different potential variations as to what you might need post-ACL surgery. I know it's obviously such a massive issue with sports people, and you might have someone in your family or know someone, one of your friends or yourself, who's actually gone through an ACL injury. But this is revolutionary in the world of ACL management and rehabilitation, and we're so lucky to have worked with Dr. Cross over the last few years in movement therapy ourselves. And we've actually taken several of Dr. Cross's patients through the cross-bracing protocol, and they have successfully healed their ACL and returned back to their chosen sports to 100%. So it's really exciting that we can see the actual work that goes into this, and then obviously the outcomes for patients themselves. So it's still got a lot of research to do, but we're super excited to be in that path with Dr. Cross, and hopefully we can keep progressing through the years. So sit back and enjoy this episode with Dr. Tom Cross talking all things cross-bracing protocol. All right. Well, thank you, Tom, for meeting with us and being a part of the Movement Therapy Podcast. And thank you for having us here at your beautiful clinic up in Sydney, Stadium Clinic.
Very welcome.
We wanted to start, we're doing a bit of a knee series and diving into the ACL and sort of everything knee related around the ACL, but we're keen to see sort of how you got into all of your sort of research and things, and more ACL focused. So how did that all sort of begin?
Okay, quite fortuitously, or perhaps organically, here in the Stadium Clinic. So firstly, I'm a sport and exercise medicine physician, and I've been a doctor 30 years and worked in sports medicine 25 years. And throughout my career, I was fortunate enough to have my father, who was, and obviously I'm biased, but he was arguably one of the top knee surgeons in Sydney/Australia for many decades. So I grew up in a medical home environment, and my mother was a nurse, and so I was hearing about ACLs when I was a child and teenager. Then I went into medicine, and as a sports medicine doctor, I assisted my father as his surgical assistant, and we did arthroscopy, ACL reconstruction, and total knee replacement. So over an 18-year period, every week I would do 4 ACLs with my father. And he was a believer in patella tendon as the favoured graft for survivorship and controlling the laxity of the knee for an athlete. So,
because that wasn't super common, was it? I haven't rehabbed a lot of patella tendon grafts.
Yeah, obviously every surgeon's got their preferences of graft choice, and that's a big discussion. And you match the graft to the patient. But my father was a big believer in the patella tendon, particularly for the high demand athlete. With bone fixation at either end. So for the first 20 years of my career as a doctor, I was taught that ACL doesn't heal. That in a high demand athlete that needs knee stability. It was very important to stabilise their knee, to protect their knee from further instability.
Sure.
So that they didn't, for want of a better word, trash their knee when they returned to sport and their knee gave way violently. They got meniscal damage, articular cartilage damage. So that was my belief system for 20 years. And for the lower demand patient, you'd say, well, why don't you try rehabilitation alone? Because you've retired from, or you're not interested in pivoting sports. You've had this unlucky ACL injury from skiing, or you've had a fall. Why don't you try non-surgical treatment, and then you can always cross over to surgery if your knee's unstable.
Sure. So
that was the paradigm, that you stabilise young, athletic, high-demand patients, and then you try rehabilitation alone with, with the lower demand adult. And then with children, if you try to go to a surgeon who understood ACL reconstructive surgery in the young with open growth plates, or you wait for the child to get a bit older so that the operation is not as challenging.
Sure.
Navigating the growth plates. And then 10 years ago in this clinic, we had a 19-year-old young woman, a netballer, who was actually the daughter of one of our reception team. So I'd known her for 8 years, and she was sitting in the clinic with a ruptured ACL, and obviously I knew her well. I knew she was high demand in terms of being an athlete. She wanted to go back to netball. She was extremely fit, a young woman. And once we diagnosed her ruptured ACL clinically and on MRI, I started having the conversation, well, we need to get you to a very good surgeon. And she said, look, Tom, with the greatest respect, my two best friends had reconstructive surgery. I went through it with them. They're in my netball team, and unfortunately both of them were failures. The graft ruptured quite easily on returning to netball. Have you got anything else for me? Like, is there another way? And so I started talking to Emma, and Emma doesn't mind being mentioned. And I said, look, Emma, you can do awesome rehab and just get quads of steel and do fabulous, proprioceptive agility training, and you might become what's called a coper, that you can cope with knee laxity or ACL deficiency. And then she said, yeah, I'll do all that. We've got the clinic here, we've got excellent physios, exercise physiologists. And then she said, Tom, have you got anything else? Like, I'll do anything. I'm really motivated. I've got time. And then I was sort of clutching at straws, thinking, what else can I offer?
There's nothing else.
And my father happened to be in the clinic, Merv. It was 2014. He'd been retired for 2 years. So this is a retired knee surgeon. And he was in here for one of his many orthopedic ailments, rehabbing in physio. And
he was a patient.
He was a patient in the clinic. Well, he founded the clinic in 2008. And Merv loved patients. And he couldn't help himself. And he pulls the curtains back and goes, what's going on here?
Always a surgeon.
And so Emma, I said, look, this is Emma. And Emma knew my father because her mum worked here. And then Merv said, look, there is something else we could offer her, and that's we could try to facilitate her healing by bending the knee. And he said we did it in the 70s with plastering people who had medical conditions where they couldn't have surgery. They had no health insurance or finance to have surgery. And they tried it, but it had a lot of problems in the 70s of causing significant arthrofibrosis, muscle wasting, osteopenia. So it had major complications because you were rigidly putting the patient in flexion for a number of weeks. So Merv said, well, we've got knee braces now. And we looked around the clinic and we saw range of motion knee braces. So we grabbed one off the shelf and said, well, maybe we can take her into flexion to approximate the ruptured ACL tissues in the notch or in the knee and bring those ruptured elements together and hold them together while they healed. And so Emma was patient one, and Merv and I came up with, well, Merv said, go take her to 90. I said, well, 90 is a bit crazy, isn't it? It's very deep into flexion. He said, look, there should be, the popliteal fossa won't be significantly compromised with neurovascularly, etc. Enough blood should get around the corner at 90. The knee will tolerate 90. We waited a few days. And then we came up with the idea of 4 weeks at 90. that's based on the principles of healing.
Yep.
Whether it's any orthopedic injury, bone, tendon, ligament, to achieve a reduction and then hold it there while it heals. Then every week thereafter bring them into extension. So that happened 10 years ago in the clinic. Emma was patient 1. We now have 899
Wow.
who have done the treatment or are presently doing it in a brace.
Yeah, incredible.
It took 5 years to get 5 patients. So 2014 to 2019, we had 5 patients.
Yeah.
They were all colleagues, friends. One was my nephew.
Yeah, wow.
These are people that knew my father and I, and that they trusted the principles of the hypothesis we were testing.
Yeah.
They knew that, that they could always have surgery if it didn't work. And all 5 of them didn't want to have surgery. 2 of them needed to brace anyway. They were combined MCL, ACLs. Well, it's actually 3 of them were, so patient 2, 4 and 5 were MCL, ACLs. So they needed to brace anyway. And we said, well, why don't you go for gold?
Just
try and heal the ACL and the MCL.
Yeah.
And then patient 6 happened in the clinic, and I've never forgotten it. And he was someone who didn't know us. He was a 17-year-old rugby player with a ruptured ACL. And he said, I was sending him to a surgeon because he was a very good footballer with a ruptured ACL, not a partial tear, completely ruptured, detensioned. And he said to me, look, my brother had a reconstruction, mum had a reconstruction, and unfortunately they were in the minority where it doesn't work, re-ruptured. Mum's got osteoarthritis, she had a revision, and then now she's got an OA.
Yeah.
I'm not really enamored with surgery. Like, have you got anything else for me? Like, can we try something else? Yeah. And I said, well, Toby, there's this crazy idea of bending the knee to 90. 5 people have done it. And the father, who was a colossus, a big 6'7", ex-high-level rugby player, he said, well, what have we got to lose? Like, if it doesn't work, we can always get surgery. And we did the maths, and we worked out that we could still get him back for the next season if we tried this non-surgical treatment. And if it didn't work, we could cross him over quickly to surgery. Anyway, I never forgot. Back then, I was doing Lockman's in the clinic, and I felt that he had a positive Lockman, that there was no endpoint. Yeah. I never do a pivot shift because it hurts too much acutely. Yeah. Yeah. And then I saw the MRI, and then 12 weeks later, we did the follow-up MRI, examined him, and I've never forgotten the feeling of that crisp endpoint, looking at the MRI, seeing the exuberant bridge of healing.
Oh, yeah, it's nice.
And after that, I just couldn't let it go. I couldn't, ethically not pursue this treatment, and that led to 5.5 years of research, and I've learned a lot of lessons. But that's how it started. That I didn't go looking for this. It just found us.
Yeah. I guess it's really interesting. I'm coming from a netball background where someone will do their ACL and the initial thought is that they just go straight to surgery. So to have a non-surgical option that has had great positive results. It's really, I think it's really exciting for ACL tears. That kind.
Did you get much pushback from surgeons in the community about pursuing a non-surgical option for this?
Well, understandably, when you disrupt or challenge a well-existing belief system or paradigm of thinking that has a 50-year history, rightly so, there are people who are concerned about the patient.
Yeah, sure.
Maybe the patient will get too stiff. Maybe they'll get a DVT. Is it just scar tissue and it's weak and it's not as strong as an ACL reconstruction? So obviously there have been clinicians, surgeons, members of the public who are very worried, but I can reassure them that we're very sensible, ethical, careful doctors that believe in efficacy, being effective, and also safety, and science. So we're doing this as scientifically as we can. Yeah. And every patient's important, and I'd spend a lot of time with the patient, their family, if they're young, their parents, consenting them for trying this non-surgical option, and also talking to them about surgery. What we've learned a lot, and Zoe, to your point, that that it's an option. It's only an option for some. So we're not saying we can cure all ACLs.
Yeah.
That's madness. Because what we've learnt is, and it's a really big lesson, is that the ACL is injured in a spectrum.
Yeah.
Just like every orthopedic injury, if you have a broken arm, you go to the hospital, and sometimes you can see, it's profoundly injured and the anatomy is grossly disrupted. Then you get an X-ray, often a CAT scan, and you get triaged into, well, that one will heal without surgery.
Yeah.
That one needs a closed reduction, and we need to give them a sedation, put it in position, put a splint on, hold it there while it heals, and that fracture needs a surgeon. So this is the shift, in that ACL is no different. And the MRI allows you to classify how badly the anatomy is being disrupted, and whether that ACL might heal with rehab alone. It might heal with bracing 30 to 90, and maybe just telling the patient to sit down for the first couple of weeks and bunker in at home with their knee at 90, or they need to go to 90 and hold it at 90 because they're a little bit more injured on the spectrum. And then the MRI will say, look, you've got a profoundly injured ACL. This non-surgical treatment is not for you, because you're not going to get the best healing outcome. And you happen to be 21, you want to go back to netball, soccer, AFL, touch footy, Oztag. You need your knee stabilised to protect your knee from further instability, because you're a high demand athlete. So, and then I would triage that patient to a very good surgeon. So it's giving the patient an option of being classified into a non-surgical option. Surely it's preferred to keep your own ACL.
Yeah, surely.
With its beautiful anatomy. It's a ligament. And I do believe that there's a spectrum of healing of the ACL, even the ones that we get full volume healing, that's parallel to the roof or Blumenstadt's line. So some of them do have a bit of scar in them, but others get beautiful integration of and remodeling of their collagen. And our survivorship of our healed ACLs, more than 1 year, is sitting at 15 to 18% returning to sport. So it's somewhere in that range, 15 to 18%. It's moving every week. We're watching it like a hawk, that metric. So if my phone started ringing today and all these ACLs were failing with these patients, when we've got 500 1 year to 10 year follow-up, I would sort of not recommend this to a high demand young athlete. I'd just say, look, the cross bracing protocol is appropriate for the lower demand adult or the young child with open growth plates who's 10 or 11 or 12, and the surgery's really challenging. But that's not happening. We are they're performing well, and so it's exciting in that we've had this discovery of the spectrum of injury that I think, with the greatest respect, we hypothesise that we've explained the spontaneous healer, that they're just a less injured ACL, that where the anatomy hasn't been that disrupted that badly. Plus, for a bonus, they sit at home all day with their knee bent. And with the greatest respect, they haven't been to a physio who said, look, straighten your leg out. They haven't been put in a Zimmer splint, which pulls the ACL apart. And they've just bunkered in at home with their ruptured ACL and worked on their computer. If they're an IT consultant, they work sitting down all day. If they're an academic or a student. So I've seen incredible spontaneous healing in people who have got sedentary jobs.
So let's go through the actual protocol itself. So the main one is it's a 12-week protocol with some variations on time frames as well, which we'll go into. But essentially, like you described before, it's a brace locked at 90 degrees of knee flexion, and then that's 4 weeks, and then it slowly comes back out sort of with each week, 10 degrees or so. What are the different sort of protocols in terms of time frames, and is it because of the different types of tears that you mentioned, or complexities of the knee? And sort of, how do those time frames work? Is it individualistic to go, oh, well, I don't think you're going to heal as much, so therefore we'll do an accelerated protocol, or everyone gets the 12-week and see what happens?
It's a great question, and first thing, this research is still a work in progress. So we're learning every month we have new lessons, and once again we're very careful to be scientific, to be very honest with the patients, and care about their safety and making the treatment as effective as it can be for them. We started off, with that story 10 years ago where Merv, my father, and I said, well, let's do 4 weeks on these principles of medicine, of achieving a cellular response and getting granulation tissue where the rupture zone once was, that becomes the healing zone.
Yep.
As you approximate the epiligament or the rupture tissues and bring them together. Just like putting bone together and holding there while it heals, or if you have a laceration, bringing the edges of the skin together and letting the skin epithelium heal. So we chose 4 weeks, but through the course of the last 5.5 years, we've had people get very stiff. And they often had a combined MCL, ACL, or a post-collateral corner, high grade, grade 2 disruption. And then we quickly said 4 weeks is too long. So we went down to 2 weeks, and we did, let's go to 2 weeks at 90 for these injuries where there's a high grade MCL and or post-collateral corner, because there's this compromise of trying to heal the ACL without getting the patient too stiff. So that was the birth of the 6-week protocol. And then a physio, lovely lady called Amir, she's Irish, she said, Tom, this 12-week one's a bit too hard for me. Can I just do 3 weeks at 90? And I said, well, Amir, you're the patient, you can do whatever you want. And she was a physio, she understood biology, rehabilitation. She said, I'm just going to do 3 weeks because this one, the 4-week one's too much for me. I've got a right knee that's injured, I can't drive, I've got young kids. And I said, look, that's totally fine. And she healed. And that was the birth of the 8-week protocol. And now we have 100 people who have done the 8-week because the 12 weeks is a bit too hard. As a challenge to them, etc. So now we're getting into the world of, you look at the MRI and the ACL injury, then you look at the patient, and then you prescribe the length at 90 that you think's appropriate. So if I saw someone this afternoon with a gap distance with the ruptured tissues are 1 millimeter apart, and they're sitting in the clinic day 7, and the physios brace them 30 to 90 from the date of injury, you're on a real winner there. And they only need 2 weeks at 90 to get an effective heal. And the patient really doesn't mind. They love that. They say, well, I heard it was 12 weeks. 4 weeks at 90. I say, no, look, you only need to do 2. The doctors in New Zealand, a lot of them are choosing just the 8-week. They just think the 12 is overkill. And it might come to pass that the 12-week one does go into oblivion. But we can't do that yet because we need data to see whether they're all equally effective. Maybe with bigger gap distances, like say Zoe, you're a tall woman. Touch wood, God forbid if you
don't do it. You got enough problems.
I don't need to do the ACL, no.
So we'd probably accept a gap distance of 6 millimeters in you, and then anything. So if you came in with a 6 millimeter gap, we definitely wouldn't do a 6 week because it's just. I think you're running the gauntlet that they may not get an effective heal. So you'd either do an 8 or a 12.
Right.
And then you tell the patient after you've done 3 weeks, how are you doing? Are you handling this mentally, physically? A lot of them say, look, I'm doing well. I want to put another week in the bank and do the 12-week because it's the most tried and tested. So you wouldn't do a short protocol for a larger gap distance. But if you had a combined MCL, grade 2, you might do an 8. You would definitely want to do a 12 to get too stiff. So it's patient MRI factors. I think down the line when we get more data, and we'll have an equation for the patient's height, the length of their ACL, the gap distance, and you'll have a bespoke bracing protocol. You actually don't need to go to 90 to get a reduction of that tissue. You only need to go to 60, and you'll know you've closed the gap or reduced the ACL. We've just chosen 90 to try and heal as many people as we can. And so I think that's what will be down the line. You'll have, and like the surgeons do when they're doing a closed reduction of a fracture, they have an II machine. So they do the closed reduction, then X-ray them again to see if they've got a reduction,
Right.
anatomical reduction.
And that's essentially just doing a manipulation where you're trying to align the bones together
Exactly.
without actually opening up the skin and going in.
So a lot of the listeners would have had either themselves, their children, a relative who's broken their arm or their ankle, and the doctors and physios have put it in position while they're sedated under anaesthetic, and then put a plaster or a splint on to hold the bones in position. So that's a non-surgical treatment of a fracture, and that's what we're doing with the ACL. It's no different. And then similar to a tendo Achilles rupture, we're treating a lot of them non-surgically now, putting the foot and ankle into Aquinas, and that is a closed reduction of the Achilles tendon tissues and opposing them. So what you could do with an ACL is do a sagittal MRI in extension. Notice that you've got a gap distance, a rupture zone, bend the knee, and then on the MRI show that what angle that you've achieved the reduction.
So essentially just seeing, does the actual tissue come back together, and what angle does it need to be for it to come back together? Based on the distance apart.
Because you could be wasting the patient's time.
Exactly.
You know, if they've got a 9 or 10 millimetre gap, and then you repeat the MRI and say, look, you still haven't reduced your tissue. You shouldn't do this cross-bracing protocol. If you're high demand and want to go back to a high demand ACL sport, I really want you to see an excellent knee surgeon to stabilise your knee.
So
absolutely.
I guess it's kind of the spectrum of injury that you mentioned before, but also expanding that to take in their lifestyle factors and that kind of thing as well. And then when reading through the documents that you sent through earlier, something that I was interested in is the window of opportunity to be able to do the cross-bracing protocol. And I was wondering if you could maybe explain that and why you've got this window of opportunity to be able to heal
Sure
it.
thing. So say this weekend in somewhere in Australia or internationally, some young athlete ruptures their ACL, and he or she, it's witnessed, and hopefully, if they're very lucky, they've got an excellent physical therapist on the sideline, or even they may have a doctor. It depends what level of sport they're playing. Or they've got an excellent GP that they can see quickly. So that's an injury, just like a fracture, and you wouldn't leave a fracture undiagnosed for weeks or months, especially when you can heal it non-surgically. So the paradigm shift is that, look, some ACLs do have a chance to heal. I need to get to a hospital or an imaging facility to get diagnosed accurately by an expert, physical therapist, doctor, radiologist. I need an MRI, and I need to find out where I've landed on that spectrum of injury, and is it healable by rehab alone, bracing 30 to 90, or going deeper into flexion to do what's called, I didn't call it the cross-bracing protocol. Stadium Physio did 2 or 3 years into the research. We were just calling it the bracing protocol. It's very kind of them to call it that. There's a lot of analogies with cruciate ligaments and crossing the knee, and so you wouldn't, if you leave a fracture unreduced for weeks, they'll either get a non-union or a malunion. So the fracture won't heal, or it'll heal in the wrong position. It's exactly the same for the ACL. And you wouldn't walk around with a big gaping wound on your forearm. You might say, I've got to get this reduced, and I've got to get some steri strips on it, or I've got to get it sutured. So it's changing that belief system that it does matter. We believe the ACL starts, for want of a better word, dying or involuting. And it's different for different people. So we could say in medicine it's idiosyncratic. Some people start sort of like a flower closing, like a lotus flower at night closing, and it's no longer got viability, even if you do reduce it to heal. Some people involute early, like in the first, in the second week. It's very unlikely, but it does happen. But most adults will be closed for business or closed for healing after 21 days. And we've healed a few children at day 27, day 33, where the parents said, look, let's just do this. Had a young girl in New Zealand who both her mum and dad were doctors. she was day 33, and she miraculously got a heal. Ideally, you should bring the tissues together when they're vibrant, freshly ruptured, and they've got all the cytokines and enzymes of healing.
And all the blood flow and inflammation and everything around that to heal.
So it's a fresh wound. And that fresh wound every day undergoes this process of giving up or involuting. We believe the ideal time to bend the knee to 90 and then bring the tissues together is day 4 to day 7. But certainly you'll get a lot of healing up anywhere out to sort of day 18. But the ideal times, and hence the changing the belief system in the community and sports medicine, doctors, physiotherapists working with athletes and people who get knee injuries, that it does matter. Like, we really need to diagnose this. And find out where they sit on the spectrum of injury, etc.
Yeah, definitely. And when we're saying sort of that the patient comes in after day sort of 4, if they do see a physio, 2 or 3 days, or even the day of or the day after, is that then, should the physio be putting them in a brace at 90 degrees, or is that 30 to 90 that you're talking about?
That's a great question. And our research group believe that if someone is unfortunate enough to rupture their ACL this weekend, like I said, hopefully there's a excellent clinician, physio, doctor on the sideline that has recognised that an ACL potentially has just happened. Someone's changed direction at speed, felt their knee give way, shift, dislocate, then go back into position, often hear a pop, a snap, a crunch. They fall to the ground, they're in agony for minutes, and then the pain subsides. And then someone should be allocated to examine that knee and do a very gentle Lockman, because every time you do a Lockman, you're potentially making that ACL injury worse.
And you see people on the sideline just jamming the knee into this point and just trying to prove that it's an ACL rupture, but you're often just pulling it apart.
Potentially. So that's another contentious statement, because all around the planet today there's clinicians examining people who are day 7 or day 14 and doing Lockmans in their private rooms and pivot shift tests. So it is contentious to say you shouldn't do it, because they're trying to test the knee for laxity to make a clinical decision on operating on them or not. But we believe that if you're lucky enough to have access to an excellent MRI, the MRI will tell you the distortion in the anatomy, how badly injured it's the ACL, the medial structures, the postcollateral corner, and you shouldn't really touch the knee and do a Lockman, because the ACL is already trying to heal, and you're breaking down all the cross-linkage and the bridging of healing. It's already happening if they've got a healable ACL. So we believe the treatment should be identify there's been an ACL, and you can talk to the patient, take a history, examine them. Never forget to ask them, have you injured your knee in the last couple of months? Because you might be looking at an instability episode rather than a ruptured ACL. The ruptured ACL happened 6 weeks ago. So, well, by the way, Ethan, I injured my knee 6 weeks ago. I had 5 weeks off because I thought I just sprained it, and this is my first game back. So you're looking at a 6-week-old ACL.
So they injured their ACL first, the pain's gone away, so they've gone back, and then the knee started to give way. And
so it's really important to ask those questions. Have you ever injured your knee before? Remotely or in the last few weeks? Most of the time, 99% of the time, it's a new injury. And then you say to them, well, I'm going to put you in a knee brace, and you try to, usually you have one with you or nearby at the clinic, put them 30 to 90 and say, look, the enemy here is full extension, because you're pulling your ACL apart. So, and it's the most comfortable position for the patient with an injured knee is inflection. They don't like going into extension. So, and then you make them non-weight bearing on crutches. Give them DVT risk mitigation exercises. Bit of compression, ice. I don't believe anti-inflammatories are a good idea, because inflammation's your friend.
That's the goal, isn't it? To heal. You need inflammation.
So you don't want to shut down all that inflammatory cascade going on in the ligament. And then you want to say, well, I want you to go to this MRI facility, because they do fabulous MRI imaging of the knee. So, and I don't mind saying it, but I really like Castle Ray imaging
Yep.
and PRP imaging.
Yep.
Because they do excellent imaging, and then they do an extra sequence called the double oblique, which gives you a really good look at the pattern of injury to the ACL.
Yep.
A lot of the other imaging companies aren't far behind
Yep.
in their sequences and the quality of the imaging and double oblique sequences. But we're trying to get it standardised, so all the imaging companies have a mandated, this is how you image an acutely injured ACL.
Yep.
This is the minimum standard. You have to have a double oblique. And then the doctor and the radiologist and the physio can not only get to know the patient, of who is this patient, what are their age, what sport do they want to go back to in 1 year from now, do they have health insurance,
Yep.
have they had an ACL reconstruction or injured knee in their other knee, do they have a strong family history, what medication are they on, get to know the patient, then get to know their MRI and what the injury is, then you go back to the patient and say, well, this is the ACL injury, and based on our knowledge so far, we believe it will heal this way with rehab alone.
Yeah.
This way perhaps with 30 to 90 bracing, and the cross bracing protocol will land you in this healing outcome. Is that acceptable to you?
Yeah.
And then the patient decides, and then this is what ACL reconstructive surgery looks like with an excellent surgeon. What would you like to do?
Yeah.
So that's that, and the patients really like having those choices. Admittedly, there's probably people listening saying, well, how much science have you got?
Yeah.
And
It's always that question. Is it evidence-based?
yeah, well, we're very experienced doctors. Once again, effectiveness and safety are paramount. But we've got a lot of knowledge with 899 patients.
Yeah.
800 that have reached 12 weeks, clinically, and on MRI, 500 more than 1 year.
Yep.
We have a very good idea of how they may heal and what that heal means in terms of getting them back to sport, survivorship. So that would be the way I would manage. If you're lucky enough to get the patient very early, is get a knee brace on them 30 to 90, non-weight bearing crutches.
Yep.
One person does a Lockman. No one else does a Lockman.
Yeah.
So no Lockmans at day 5, no Lockmans at day 10. Get them diagnosed with an excellent MRI, and then go back to the patient. On the MRI, there may be other injuries in the knee where the bracing protocol and non-surgical management is completely off the table.
Yeah.
They need a surgeon.
Yeah.
So they've got an unstable meniscal tear, a bucket handle sitting in the notch, a cartilage tear.
Yeah.
They've got an osteochondral loose body. They've got a significant posterolateral corner injury that needs a surgeon. So that's why you need an expert radiologist, clinician, brainstorming the case and making sure that no one goes into this bracing protocol where you're setting them up for failure.
Yeah.
And so it's got to be done very carefully, professionally.
Yeah. And I think we'll touch on about later when we talk about the rehab, but the team is so important of the clinician talking to the surgeon or the sports physician, and then the radiologist as well, to go, oh, well, I'm not sure about this angle, can I have another opinion or another angle, or what have you, to at least get a clearer idea of what other injuries might ensue, fractures, PCL, LCL, like other ligament issues. Is that a contraindication if there are other ligaments damaged, or is it more the meniscus that you're looking for when that blocks it?
Well, we'll go back to the moment in time that ACL gets injured.
Yeah.
There's a certain amount of force that goes through the knee in that episode of injury. So the faster they're running, or the higher they've jumped, or the faster they're skiing, at that moment of knee injury where the femur rotates on the tibia, most likely, and goes out the posterolateral corner, so there's an external rotation of the femur or internal rotation of the tibia.
Yeah.
There's a certain amount of newtons or newton meters of torque or force, and the ACL's injured proportionate to the amount of force.
Sure.
So the greater the force, the more severe the ACL injury.
Yeah.
Because the femur subluxes a greater distance on the tibia, and that greater distance or subluxation leads to a much greater ACL anatomical disruption.
Yeah.
Gap distance is much greater. Tissues violently thrown out of the notch, synovial envelopes breached, plus you've got all these other concomitant injuries that coexist with the severely injured ACL. The posterolateral corner, because there's been such a subluxation, is grossly disrupted.
Just go into that, sorry to interrupt, the posterolateral corner and the structures involved in that for the listeners who might not know what that is.
So that's the area if you're looking down at your left and right knee, it's on the outside at the back. So the corner on the outside, to the outside of your knee and then going around the back corner. Yeah. So it's posterior in Latin or in medicine is behind, and then lateral is to the outside. So posterolateral is that corner on the outside. Yeah. And when your knee subluxes and injures an ACL, the most common mechanism of injury is that posterolateral subluxation of the femur on the tibia. And then if you get a very significant subluxation where the femur goes all the way out a long distance and then all the way back in, you can injure the capsule, which has got a whole lot of different names, arcuate complex. Yeah. Then you can injure with the lateral collateral ligament. You can injure the biceps femoris attachment on the fibula.
That's one of the hamstring.
Yeah, one of the hamstring tendons. So if there's a significant anatomical disruption, you need a surgeon to put that to repair that. So they're high velocity, high force knee injuries that result in severely injured ACLs with all these other concomitant injuries. Concomitant means associated. So meniscal damage, injury to the posterolateral corner, injury to the medial ligament, injury to the lining of the joint. Yeah. Now, a less injured ACL with less force that we think is healable usually doesn't have these other significant injuries. So there may not even be a bone bruise.
Yeah, right.
Because they're getting off the chairlift and going 5 kilometres an hour. Yeah. Get tangled up in the skier next to them. Yeah. Feel a pop in their knee, and then the knee just doesn't feel quite right. It feels a bit loose. They can weight bear on it. Very different ACL injury to the elite skier going 100k an hour.
Sure.
So, don't just think about the ACL, think about all the other injuries, but they usually coexist. Profoundly injured usually has other injuries that need a surgeon.
Okay, we're going to leave it there for this week's episode. Thank you so much for being a part of the episode and listening along. If you have any comments or questions about the episode or just want to get in touch, please reach out to us via any of our social media links or emails that we provided in the show note captions. And like always, please share this content with anyone who you think might be interested. And we're so excited to be back for part 2 next time.